Hello, we're glad you've joined us for this live webinar, Total Cost of Ownership, How to Improve Laboratory Operational Efficiency and Deliver More Value to Your Healthcare Organization. I am Christina Mahalik of LabRoots, and I'll be your moderator for this session. Today's educational web seminar is presented by LabRoots and sponsored by Abbott. At Abbott Diagnostics, we know that better information is key to better health. That's why we develop pioneering technology that transforms the way you turn accurate, timely results into smart decisions and exceptional outcomes. We span the world of healthcare operations with medical diagnostics, instruments, tests, automation, and informatic solutions for hospitals, reference labs, molecular labs, blood banks, physician offices, and clinics. And our dedication to in vitro diagnostics doesn't stop there. Our wide range of supporting materials and tools, including education, training, and scientific publications, can help you optimize workflow and efficiency throughout healthcare institutions. Now, let's get started with today's webinar. A few quick reminders. You can submit questions to the speaker during the presentation. To do so, simply type them in the Q&A box located at the lower left of the presentation window. Questions will be answered after the presentation. To enlarge the slide window, click on the screen icon in the lower right-hand corner of the slide window. If you experience technical problems seeing or hearing the presentation, just click on the support button found at the top right of the presentation window, or report your problem by clicking on the green Q&A button at the lower left of the screen. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of the webpage and follow the process for obtaining your credits. I would now like to introduce today's speaker, Patrick Gontard, Group CEO, Labexia Group, France, CEO and founder, Gontard and Company, Switzerland. Patrick Gontard possesses more than 25 years of medical industry experience in a variety of senior leadership roles across laboratories, hospitals, and professional medical associations. Known as a subject matter expert on the topic of total cost of ownership, TCO, Mr. Gontard has developed and implemented a TCO model which has been applied in laboratory settings to become an evidence-based, real-life management tool for calculating and controlling costs related to laboratory and hospital operational efficiency. Responsible for restructuring and management, including commercial and scientific leadership in various laboratories throughout Europe and the Middle East, Mr. Gontard's CEO methodology has helped to uncover and quantify hidden or indirect costs and deliver operational efficiencies and improvements in profitability. Patrick has perfected his total cost of ownership model over the years, working for organizations such as Voulier, the second largest Swiss lab group, Integrated Diagnostics in Egypt, CityLab, the second largest lab group in Russia, and currently is the lab CEO at Labexia in France. Mr. Gontard will begin his presentation.
Hello everybody, it's a pleasure to have the opportunity to talk to you. Thanks for the introduction. TCO, Total Cost of Ownership, a reported result, is a methodology I started 20 years ago, and as said before, I have perfected over the time. We have various publications. We're doing education seminars such as this one, and it's a pleasure to take you a bit deeper. So let's dive in. So, what do you see on the screen? I see a French fry with a bit of ketchup, Anybody has an idea why I start my costing presentation with a French fry and a bit of ketchup? No? Let's go to the second slide. A different French fry, different length, with another bit of ketchup. Third slide, a bit of the same but a shorter slide with more ketchup compared to the rest of the fry. So to cut a long story short, we look at the main assays in a laboratory operation as French fry. Each unique assay, and we have about 2,000 in catalog, is represented by an individual French fry. And we look at the cost of technology as the part of the ketchup on the French fry. So you will tell me, okay, but I have 2,000 catalog object, 2,000 unique assay, that's a lot of French fry, I might get an indigestion. I would say you're not wrong, and therefore over the time we have noticed that the Pareto law applies to laboratory medicine. If you look at your core lab, you will find that according to the kind of laboratory medicine that you do, that between 20 and 30 assay make between 70 and 80% of your biochemistry volume, and that 20 to 25 assay make the same percentage, 70 to 80% of your immunology volume. So if you look at, I would say, 40 to 45 assay altogether, you have already 80% of the volume of your laboratory. We have looked at laboratories in Europe, in the Middle East, in Asia, and the numbers are fairly consistent. If you're a commercial or a public laboratory delivering primary care laboratory services to population, GPs, and hospitals or referring clinics, you will be roughly in the same ballpark. So basically what you have to look at is not to have to study 2,000 French fry, you have to study 45 French fry. Now let's go back to the French fry and why I started my presentation with French fries. Well, we have noticed that the main concern of colleagues is the percentage of reagent and technology cost compared to the total cost. And if you look at the French fry, you will see that the non-ketchup part is the pre-analytics and the ketchup part is the analytics. If you look at the three components that are highlighted on this slide, you can do a study assay by assay and see that the percentage of money spent on the assay, the percentage of time spent on the assay, and the percentage of problems arising related to the quality of the performed assay are consistent. If you go back to literature and the IFCC study on number of problems arising from pre-analytics, you're at 75 to 80% of problems arising from pre-analytics. When we do survey of the labs we manage, and at the present time we manage about 6 groups of laboratories, and they're in different geographical areas, but they're always fairly consistent. The percentage of reagent and technology cost compared to total cost is usually between 15 and 20%. For biochemistry, in some cases it can go down as low as 9%, but this is in extreme cases. So if you look at my French fry, you will see that the 20% of reagent and technology costs represent the ketchup. This is why I started my presentation with a French fry and some ketchup. Now, immunology and biochemistry are very different. Nevertheless, you will see the same kind of distribution. And if you want to understand how much it costs to perform 80% of your volume, you need to focus not only on the ketchup part, but on the full French fry. And this is what we're trying to do with the TCO. We're trying to get up and get out of studying only the ketchup part to studying the total cost of performing the assay. Usually, when you ask people what is the right percentage of ketchup compared to the total length of the French fry, people have a very precise ID, and it's an aggregated ID for the whole lab, for the whole year, for all the departments, and they come up with a percentage, and they say, according to my profit and loss account, I'm at X%. And if you ask them what is the ideal percentage that they would like to reach, they come usually with a percentage that is lower. So basically, if you look at the graphic that you're looking at, they would like the length of the French fry without the ketchup to be longer. Well, let me disagree. If you ask me what is my ideal percentage portion of the French fry with ketchup, I would say anywhere around 50% and over. Not that I want to have extreme technology costs, on the opposite. Me and my team, we usually operate in difficult situations, in situations with changing payment environment and with different currencies, with devaluating currencies. When I arrived in Egypt, we had a big devaluation and 3 revolution. When I arrived in Russia, the ruble was at 32 ruble for $1, and now it is at 64 ruble per $1. So the cost of technology is extremely important, and this is why we developed this methodology. So coming back to the French fry and my ideal 50 to 60%, I'd rather chop the non-ketchup part of the French fry than have a very little ketchup compared to the total length. Meaning, I'm more interested in how my ecosystem delivers the total cost per reported assay than just the percentage of costs that I dedicate to technology. I will be a bit more specific. I will talk to you about 2 big clusters. The first one is the non-production environment, which is the pre-analytics, roughly put. And then I will talk to you about the production environment, and I will describe you the characteristics that are evidenced in the TCO. And then I will take you into a more precise case, which is the CityLab study, where we did we had the privilege of having 2 competitive platforms on the production site, and we did 1 full month production on 1 platform and production volume, the whole volume, and we did a 2nd month on the competitive platform for the same assay, and we compared all the costs, not just the technology costs, but the staff cost, the electricity cost, water costs, all the indirect costs, all the variable and non-variable part of costs, and we came up with a publication that showed a very big difference and a very big change from our initial perception. So let's go into the non-production environment. I had the privilege to start my lab career at a very good organization in Switzerland headed by a visionary person called Edouard Violier, and his approach to philosophy and to the way that he structures the lab had a tremendous impact on all the costs, and we devised a method of quantifying how this unique philosophy applies to the costs. Unique philosophy means that not just philosophy of production, philosophy of catalog, but it's, are you tube-centric? That means, are you focusing on 1 or many tubes? Are you patient-centric or are you request-centric? Do you have a unique patient number? Do you have a unique barcode number? Do you have a unique tube per machine or per department? Or do you aliquot? Do you have a clear production concept that is applied through all your production sites in the group of laboratories, or do each laboratory potentially produce on a different technology, on a different platform? Do you have the capacity to reintegrate all these results into 1 single LIS, or do you have multiple LIS? Do you have multiple LIS and a unique middleware? So when I refer to unique philosophy, it's all the derivation of unique, and this could be just a webinar in itself. how to unify and standardize production, values, philosophy, pre-analytic rules, sorting rules, and logistics in order to chop off the non-ketchup part of the French fry. To give you a very simple example, in one of the labs we manage, we have multiple production sites with multiple platforms, and one of the platforms requires a systematic aliquot. So guess what? This platform looks cheaper if you look at just the reagent and technology costs, but when you reintegrate the aliquot and the time that is needed and the costs that are linked to performing the aliquot, without talking about the risk of contamination and integrity of the sample, you get a very, very different financial picture than what you look at when you see only the aggregated costs from the accounting department. Second characteristic of cost-efficient labs is they have a very clear focus on science, and they make sometimes hard choices that look expensive but then prove very, very efficient on the medium and long term. That means that you have results that can be trusted. You can move samples between locations, you can do aggregates, and you can do historical, and you can do delta checks that mean something. Third aspect is the respect of standards and accreditation. If you have a group of laboratories with multiple production sites and you're in the process of accreditation and you have multiple platforms, it might become a nightmare to standardize and to get a proper accreditation. And when somebody asks you, what is your percentage of accreditation, you have a difficult time answering. And in some cases, you give numbers that are not valid. And when you know that accreditation is going to be one of the key elements for reimbursement level, you better have something that is solid. And the TCO enables you to quantify the cost of accreditation and see the benefits of the investment you do in the accreditation process as you do it, and not just consider accreditation and quality management as a burden imposed by regulatory authorities. Another aspect which is extremely important, usually staff costs, I'm talking about continental Europe, is about half of your costs, of your total costs, so it's much more than the ketchup part. So you'd better have qualified staff and unique qualification mechanisms so that the quality of the performed assay and the reproducibility of your performed assay is guaranteed. Technology is critical because modern laboratories are extremely technology intensive, and to know how to deploy technology properly is the key. And TCO is the key on understanding how to take the suppliers at their promise and making them participate in the development of the technology concept, so you don't basically make a bet on a tender result or on an offer based purely on a price list, but you also have them participate in revamping the production concept and in making sure that you can produce quality results in time in a cost-efficient way on the medium and the long term. The last object of the characteristic of cost-efficient labs is a very clear production concept. Most of the time when we walk into laboratories, there's far too many machines and there's far too many systems. We're not against multiple vendor platforms. Actually, we operate only multiple vendor platforms. We don't have a single platform that is a single vendor. And instead of doing vertical production concept, we do horizontal, where we give each family of assays to one producer or one supplier, and the next potentially to another one. That enables us to move samples between production sites and to reduce the number of machines deployed, and we use one site as a redundancy on the other one instead of having 2 or 3 times the machine on location to enable us to have a non-break of production. in case something happens to one of the machines. Most of the costs, if you look at it correctly, are in the pre-analytics, whether because the quality of the biomaterial is not satisfactory, whether because the biomaterial is not labeled properly or has not been centrifuged in time, or because the wrong tube has been used, or because people don't use gel separator tube for serum and they have logistics time that are more than 2 hours. You would not imagine how much a wrongly labeled tube costs to a laboratory in terms of disruption, in terms of loss of credibility, in terms of interaction with the prescribers and with the phlebotomy staff, and in terms of interaction with the patient. Sometimes you have to do rephlebotomy, and it is not very nice for the laboratory to have to go into such aspects. Sometimes also the barcodes that you're using make no real sense. That means that you have the same barcode for all the tubes in the same request. That means that you need manual sorting afterwards according to the cap color in order to distribute the tubes on the various analyzers. And that reflects into very high costs outside of the production, when you could have much leaner cost if you had done your homework on the philosophy and on the barcode labels. Many people underestimate also the importance of the quality of the biomaterial. That means the temperature control and the fact that the proper tube is adopted. Sometimes people make a 2 cents arbitrage on the cost of the tube that has a $2 effect on the effect of the reported assay. We also perform a custodian chain, enabling us to timestamp every time the tube closes and changes a process from one department to the other. That means we always know at any point in time where the tube is, and we can know who was the last department or person that had the custody of the tube. Something that is also very important that we do with suppliers, whether pre-analytical suppliers or analytical suppliers, is we do constant education of our prescribers in order to make sure that we get the samples that we should get, and the quantity of biomaterial that we should get, and the quality of the biomaterial that we should get, in order to be able to produce results smoothly without having to spend resources trying to compensate for some built-in problematics that have been generated at the source. It is always difficult to talk to prescribers about the quality of the biomaterial or how they handle it, because they feel that they have done their job just by doing the phlebotomy, but in fact that's where the problem starts. And we have noticed that the first 5 minutes of the discussion is a bit painful, but after that they're very eager to be educated and to change their way of handling biomaterial. One of the largest excuse and cost generator is lost tubes. And lost tubes are not usually declared as lost tubes in the laboratory. There is a magic excuse that pops up that is not enough biomaterial. That means that you don't lose phase, and the whole chain of the laboratory don't lose phase, but still you have to repuncture the patient and to take it, to take again a sample. We had some occasions where some of our lab operators thought they could go for cheap pre-analytical tubes, vacuum tubes, and in fact it was 20% cheaper. Their solution was 20% cheaper. The issue is that it was really of bad quality and there was not enough vacuum, so we had to take on average 5 tubes to get enough biomaterial. So effectively 80 is cheaper than 100, but 400 5 tubes is definitely more expensive than 100. So we have noticed that the philosophy towards quality and qualification is a tremendous cost generator in a hidden way, because it doesn't show on the technology and reagent part, but it shows in the non-ketchup part of the French fry. To finish, the philosophy of reruns, we have noticed in our labs, in the lab we take under management, that there's a very high percentage of rerun, either because people go by the standard procedure, but they don't read the standard procedure all the way to the end, because they rerun the same tube on the same machine with the same lot number, with the same calibration, with the same everything. And guess what? Usually the result comes out exactly the same. So a rerun rate of 12%, like we see in some of the labs we take, is not acceptable. If you look at some of the contracts of cost per reported results, the percentage of rerun integrated in it is quite high as well. And guess what? In the cost per reported result, you pay for it indirectly, and you pay for it whether you have the rerun or not. So let's go now to the production environment. I talked briefly about the unique platform for each test cluster. That means that we could have biochemistry on a supplier, immunochemistry on another one, hematology on another one, and so forth. We have noticed, mainly in continental Europe, that some markets, and in France right now we're facing this very, very seriously, people are afraid of automation and machines, and they're trying to block any kind of effort towards more machines in the lab. The only thing they want is they want a track, and they think that the track will solve all their solutions. But in fact, we practice a very careful deployment of machines and automation, because everything has a cost, even if it's supported by the supplier in a general contract. When you have machines, you need to connect them to LIS or to middleware. The old philosophy of connecting everything to the LIS now is a bit obsolete because of the cost of connecting directly to the LIS, and because some groups resulting from aggregation by purchase and acquisition have multiple LIS inside of the same group. The only way to unify and to reduce the cost of production is to have a middleware, so your LIS can talk to each other, and so your machines can talk to each other without having to go into complex integration of data. Quality control and how you perform it is also a very, very critical generator of costs. There's various philosophy there, and each technology has its philosophy. We have right now groups that are big enough to have internal quality control where we cross-reference labs against each other. We also participate in external quality control. Nevertheless, we try to make an integrated quality control system where, by unifying our platforms, we can also cross-reference easily our platforms. In some markets it is too expensive to do mechanically or automatically on the machines. For example, in Russia, some tests are so badly paid by the public or by the hospitals that we have to do it manual, especially in the ELISA department. And therefore accreditation is extremely important, because then quality and costs are person dependent. If you have good SOPs and a good accreditation mechanism, your costs are in check. Otherwise, you can have explosive costs, especially when you open plates, 96 well plates, and you have four wells that are used. So you really need to look at these things very, very carefully. Auto-validation, if you have a proper middleware and a proper LIS, and you have done your homeworks on the parameterization, then you can really use auto-validation to free some very highly qualified time for the cases of interest, and not just to validate the routine. This is valid for France, this is valid for Russia, this is valid for Egypt, this is valid for many countries in Europe and the Middle East. Too many people hang on to human validation because they think that this is their job, and their job is to validate routine, and if they stop validating excuse me, if they stop validating routine, they will be fired. In fact, we have noticed that by dedicating the time of our doctors and biologists to the cases of interest and to scientific work and to use auto-validation platform, either integrated in the middleware or in the LIS or both, we raise the level of satisfaction of our staff and we raise the level of satisfaction of our patients and we lower our costs. And this is important, and TCO is a good way to show it. Another very important characteristic when you look at costs is, do you want to produce every assay on every single production platform you have? If you have 7, 8 production sites, should you produce everything everywhere? Should you produce only the routine everywhere and the exotics in the center? This is a very, very key question, and to answer that you need to do total cost of ownership per reported result per location. That means to know exactly the same assay, for the same assay, how much it costs to produce in this location versus the others. And then you need to make decisions. We don't use turnaround time anymore in my labs. We use total time to results because total time to results reflects the whole length of the French fry, and turnaround time reflects the time of the ketchup. And our patients and our prescribers are more interested in the total time to results than in the time it takes to turn around results in the lab. We are also very, very strict in how we qualify stat versus routine. Most of the time stat is abused and over-abused as a way to get some results a bit faster or because the routine is too long. We need to make constant arbitrage between technology, staff, and how fast we want to give results. And to make these arbitrage, it's like banking or financial arbitrage, you need tools, and TCO is a tool to do this. To make our arbitrage, we need data, and not only rough data, but data that can be trusted. And data that can be trusted is really the key. Most of the people look at data. It's like if you were flying an airplane and your altimeter is saying a certain altitude, and in fact you're not at that altitude. It's very dangerous, especially if you work in difficult environment in terms of payment or in terms of access to technology. In my labs, the first thing we do in the first months is really to test all the data system and to create an ecosystem of systems that deliver us data that we can trust. And we extract data. We don't like Excel sheets. We don't like people giving us data. We like to extract it. So people cannot hide behind fake data anymore. This data shows us that machines have personalities, and these personalities can be influenced. And according to the various part of the day or the night, you can have different personalities on your machines. When we do our arbitrage, then we design theoretical models, we validate them with retrospective data, and we also introduce scenarios, and we make evidence-based decisions. And this is the preliminary to the TCO models. When we do TCO, and we do TCO constantly, it is basically to help us make decisions with regard to technology, with regard to procurement of technology, or with regard to change of technology or rebalancing of some assays between some of our suppliers. The main thing that people ask us when we look at the lab is, should we have a track or no track? And we say, track or no track, this is not the question. The question is, how fast do you want to give results, and what are you ready to pay for that? And does it make sense? Can you evidence the benefits of one solution versus the other? Usually the answer is no. What we've noticed is that when you want to change technology, basically people propose you systems, and the systems are fairly close systems, and usually you take one supplier because you want that if there's any problem, you know who to go to and who to ask the questions to and who to hold accountable. The issue is that most of the time the systems that you're getting are not understood and mastered by your staff. And therefore, you're the victims of something bigger and something more complex than you ever imagined. And your staff is usually the victim of decisions made by the accounting department or the procurement department, and then all the after problems, the after overcosts, explode in their face, and they have no way to get out because the contract length is 5 to 7 years or more. In this respect, we've noticed that most of the time the new systems are usually designed to reproduce the old processes. So basically you put additional technology, additional IT, and the only thing you do is you reproduce the old system because it keeps people in their comfort zone, and people hate change. And laboratory medicine is a very conservative environment, and change in laboratory medicine, especially in the little processes and in what you do when with what tube, is critical. We have less and less qualified staff available in Europe, so the age or sorry, my English, the length of time that the person had worked for the lab is fairly long. So you have people that you've worked with for 10, 20 years, and you're quite reluctant to change the processes. Nevertheless, what we notice, and the costs, the length of the French fry is basically an aggregation, a sedimentation, a vertical sedimentation of all kinds of costs that are induced by old processes that are overlapping or that are redundant. And unless you clean the processes, you cannot do an evolution in technology. And to clean the processes, you need to know how much each process costs. We have noticed also that in many cases, the tender documentation given to the supplier is full of bias, and basically they're designed to make one or the other be favored in the assessment. And that shows as well in the solution that is delivered and the costs that it generates. And this is for us a very big problem. We work as well for public or for private laboratories, and guess what? They have both the same problems. The public labs have to do more or better with a defined budget, and the private laboratories, they're usually confronted to less and less reimbursement, so they have to improve their efficiency, both for the public as for the private laboratories. We have noticed as well that the system ancillaries, that means the connections, the IT, the procurement, how the warehouse is structured, is extremely important when it comes to cost generation. You can have the best platform if the feeders to that platform, the feeders of tubes, the feeders of logistics, the feeders of reagent, the feeders of calibrator, the feeders of human resources are not properly designed, your fantastic platform will become very inefficient and very efficient. So as a conclusion for this little section on the technological steps, TCO is much more than the cost per reported result. The cost per reported result is the technology part, and basically what we've noticed is that there's a very high percentage. I don't want to say a defined percentage because it changes from contract to contract, but there's a high percentage built in by the supplier to protect itself from some of your employees over-calibrating, doing reruns, and then because they have noticed that when they are in a CPRR environment, the staff has absolutely no accountability when it comes to overuse of the technology and the reagents. And that is not talking about the hidden costs outside of the CPRR. For example, some of the consumables are not included in your cost per reportable result. Definitely the time of your staff that is spent for things that are not necessary is not included. Some technology have onboard dilution and some don't, for example, and the ones where you don't have onboard dilution, you need the process to be interrupted, you need somebody to take out the tubes to do manual dilution and then to put them back on the track. So in the CPRR, you might have a very cheap CPRR for these assays, but then you compensate with people and with manual processes, and with manual processes comes the possibility of increased mistakes and increased costs and increased stress. And stress is a really, really big cost generator in laboratory medicine. When it comes to quality, because quality is one of the three components of the TCO quantifies the cost, so the money, the time, and the quality. TCO is like a 3D model for each assay, where you get a 3D coordinate for each of your unique assay, and you see your assay move in time. As you improve your processes, you see your assay get closer to the point in space where it should be to produce really quality, in time, efficient results. Quality, I work in some markets where you can purchase an ISO accreditation for $5,000 and you don't have to do anything, and you will have the certificate and it will be valid. So there's the perception of quality, and there's the reality of quality. All my competitors that have only focused on perception of quality have had tremendous overcosts, and the reality of quality is that quality is built in all your processes, all your documentation, all your standards are respected, and you should not accredit or certify bad processes. You should clean them before. And guess what? The machines are rarely wrong, unless a man told them to be. So quality can make a machine go wrong over and over, a process go wrong over and over. So you really need to clean your processes and integrate quality in the processes, because that shows in the TCO. So now let me talk to you about the CityLab story. The CityLab story is a story of how 30% more expensive reagent generated 25% less results, less expensive results. We were changing technology. We had an old platform, and a competitor came and said, I can give you 30% cheaper reagents if you signed for so many years. And the previous management said, of course, and they signed, and they didn't look into any of the problematics that we looked at in the previous 40 minutes. And basically, when they started operating the new platform, they had costs that were 30% more expensive, between 20 and 30% according to assays. And they were lost, and they went aggressive at staff, they went aggressive at the production people, they went aggressive at the supplier, and then they asked me to come and to clean, and it took us 2 years to clean, and we studied and we documented the cleaning process. So CityLab is the second largest laboratory chain in Russia. The location where we did the study has about 10,000 tubes per day. Most of our approach towards cost were the traditional approach to cost. It was driven by accounting, and it was reagent costs, final discounts, and bundles. And it was mostly direct costs. And when we looked at the profit and loss account and the EBITDA, we were really not in good position. So what we did is we did a holistic approach instead of a classical approach. We created a multidisciplinary team with finance, quality, production, medical, HR, and internal audit people, and we applied the TCO methodology, which is we did a theoretical mathematical model of costing, assay by assay, location by location, and we did an initial validation with retrospective data from the past. We did a small to see if it was correct, and then we did a large-scale retrospective validation, and we compared the two platforms just based on the information that was in the pamphlet or that the suppliers gave us. We did multi-parameter monitoring, and then we repeated that study. And the result of the study are that we not only took the direct variable cost, but we took also the indirect costs into consideration, the fixed direct and the fixed indirect. And we calculated everything. We extracted data, and we had people on the production floor from both suppliers with stopwatches, with cameras, and we shared the LIS information, we shared the middleware information with everybody, and we really did a scientific methodological approach towards our costing. This shows you the number of people that we had. So the two solution providers are mentioned here. We had, for one solution provider, 2 people during the study. For the other one, 3 people. It took us 6 months to do the mathematical model, the complex mathematical model for immunochemistry and clinical chemistry. And it took us 3 months to apply it and 1.5 months to look at the results. Basically, we look at what we consider the cost of production, which is what you would consider the CPRR, and then we add up all the other components. The results are not really interesting per se, but what we look at is that immunoassay, where the difference was not that striking in terms of pricing compared to volumes, but nevertheless one solution was 17% higher at the beginning, ended at 33% lower. And when you do more than 10 million tests a year, and out of that 80% is 45 assays, and you do the wrong decision, then your cost at the end of the year are very different, and your profitability or your efficiency if you're a public lab are very different. So let me take you into, and this is the very, very shocking part. We were absolutely sure that one of the solution provider would be unattainable in terms of efficiency because the price difference on the reagent was so high for clinical chemistry. And in the end, when we reintegrated all the cost components, we noticed that it was in fact lower. I will give you an example of clinical chemistry at the end of this presentation, and you will understand how this mechanism works. So for and again, this study, I would like you, if you have the opportunity, to read the publication we did, because this study is platform dependent, volume dependent, and solution specific. That means that this study and the result of this study are valid for our laboratory, our volume distribution, and the platform that we had deployed at the time we did the study. This is not an absolute result. I'm not saying that one solution provider is better than the other one. I am saying on the opposite, that what is important is to have a methodological approach that enables you to see the difference between the two suppliers, because if you only look at the first line of the costing elements, which is the technology costs, then you are in a bit of a puzzle at the end of the year when you reintegrate all the costs. Let's go straight into the example of a TCO. So a TCO is basically a mathematical model that is then programmed into a data extraction module to extract the data from the middleware and the LIS, and is summarized into an Excel sheet. The Excel sheet, you're seeing the first component of the Excel sheet. What is important, you see, it's, let me take my arrow. So you see that it is glucose. You see the two solution providers. You see the date of the study, and you see some of the components that we're looking at. But let me take you further into the file. So this is the second part, still for the same assay, where we calculated and we documented. And what you see here is calculated data from the big mass of data that we extracted. So we have 46 such spreadsheets for the study. Each assay has its own spreadsheet, and You will see at the end, I will show you the statistical cohort that we integrated. We have about 6.5 million data points in this study for the 46 assays. What is important is if you look at this line, you see that the reagent cost for one solution provider is 80 cents of a ruble, and for the other provider it's 4 rubles. So the difference is a multiple of 5. And it's glucose, which is a very, very big object for us in most of the labs. It's in the top 10 always, and sometimes in the top 5. And when you go further down in the model, you see that at the end of the day, what was 80 cents of a ruble became 50 ruble, and what was 4 ruble became 31 ruble. And for me, this was a very big eye-opener, because we lost, in currency terms, in dollar terms, we lost half of our reimbursement in Russia with the devaluation. But the technology cost didn't change much, so we had to be super efficient. And when we did the study, we understood why we were basically stuck into a paradigm where we had chosen a cheaper solution provider and it was generating more expensive costs. Now, I will take you back to the slides that were earlier, which is the summary of our results. Basically, the cheaper reagent solution proved overall more expensive. Not because of the supplier or because it's better or worse, but because the technology is different. And some of the philosophical choices, especially regarding aliquoting and regarding manual resources and regarding automation, had not been thought properly. We were able to identify each of these single individual objects with a TCO methodology, and if you ask for the white paper that we published, you will have much more details. Today is a really brief first pass into the TCO methodology and how the elements that we looked at the beginning of the presentation can be represented in the spreadsheet, and how you can then make informed decisions about technology and not just be the victims of your procurement decision or victim of the result of a tender that was not forcibly prepared correctly. Now, my take-home message is that the TCO is really a tool. It's a tool. It should be the first tool and the last tool of improvement, because it's the tool of the evidencing of the T0 cost base for every individual assay that you want to study, and it's also the tool for the last assessment. That means we do and we perform regular TCO for the main assays every 3 to 6 months. We reperform the TCO study on a smaller cohort, and we see if what the changes we have introduced are delivering the results we want, if we're improving the efficiency, if we're improving the quality, if we're improving the cost. And if not, we look at where it's blocking and how to address this in a more efficient way. We also use it internally as an evidence-based cross-functional management tool. We show, for example, procurement, what's wrong order when they purchase for the production, how much that generates in terms of overcosts, and they become much more aware of how sensitive it is for us to have the right objects to perform our production correctly. And we also use it with human resources and with heads of department in better managing their teams. And basically, we brought evidence-based into laboratory management. And everybody now that wants to claim something or to address a colleague or another department in modifying their process because they have a vested interest, comes with some elements of the TCO and say, look, this is the fine, this is what you did last month, and this is the impact it had on the cost, and now we look like the bad guys, but in fact it's a shared responsibility. How can we address it for the future? So the cross-management, the cross-functional management tool component is extremely important, and I would say that sometimes you're stuck into contracts that are medium term and you cannot change the way you procure your technology so fast, but you can at least start with the TCO and use it to improve on the existing platform, because most platforms can be improved providing you can show people the result of their actions, and the TCO is, for me, the gold standard in showing the effects of the action of everybody on the production time, on the production cost, and on the production quality. In some countries, we also use it as a discussion mechanism to talk to the reimbursement authorities, and we show that it really costs that much to produce a result. Because if you go with a CPRR, you're in no position to discuss a reimbursement. You know your technology cost, and that's it. And we use the TCO as well to talk to suppliers, and we say, okay, you want us to take your technology, nevertheless we want you to work with us in chopping the non-ketchup part of the French fry, in other terms, to help us be more efficient in our process. And we basically tell the suppliers, okay, we will take your technology, even if it's a bit more expensive, or if it's the same price as what we had before, we will not ask for a dramatic discount. Nevertheless, we want you to bind yourself to help us produce this number of assays much more efficiently. That means that the suppliers assist us in being more efficient. And in Russia, we had built in a variance percentage. That means that the total cost of ownership per reported result for the assays that were in the study could not be more than 3 to 4% expensive than what we had evidence in the study, and that if for any reason they were suddenly 20, 30% and we could not fix this jointly very fast, we would have the opportunity to break the contract, because a tender is an obligation, but we make a commitment based on parameters we know, and sometimes the parameters that you have to execute the contract of the tender with are not clear, and they have not been designed by production people, and the costs are not in line. So for that we use the TCO. We use the TCO internally. We use TCO to choose the technology. We use TCO to verify that our choice was correct. We use TCO to talk to suppliers to get them to work in the same way we do and to align their interest with us. And we use the TCO with the staff in how to improve the process. Now, as a conclusion, I will just show you the statistical cohort. Whoops, what is this? Let me take the arrows away. The statistical cohort that was included in the study. So that's the volume for 1 month for a certain number of parameters on one of the suppliers' platform. And this is the volume on the second supplier platform. And you will see that it's fairly similar. But I really encourage you, if you want to have a better insight into the TCO and what it means, to ask for our publication, for the white paper, and to send us emails, because we're more than happy to share this model. The more laboratories use this approach, the better we will be in talking to the various members of our ecosystem, whether it is the payers, whether it is the suppliers, whether it is the technology providers, whether it is the informatics providers, whether it is the unions. Sometimes we use TCO to talk with the unions and to show them that to block a certain change in the process is an absurdity, because we could pay people more if they were helping us change the process. But anyway, I think my time is coming to an end. So I would like to say thank you, and we're here to answer your questions.
Thank you, Mr. Gontard, for your informative presentation. A quick reminder for our audience on how to submit questions. Simply type them in the Q&A box found by clicking on the green Q&A button at the lower left of the presentation window. Mr. Gontard will answer as many questions as time permits. Okay, let's see. Our first question asks, what % of your total costs are represented by reagents and technology, and what should this number be in an ideal situation?
Very, very nice question. It brings us back to the French fry. So, in Russia, it was about 26% of our total costs were reagent and technology. In France, it's a bit less. It's around 15%. And you can imagine that the ideal number, if you go by the classical method, you would like that number to be low. But in fact, a low percentage of technology cost means a very high percentage of non-technology costs. And I'm not interested in the percentage of technology costs. I'm interested in how much it costs totally, the total cost of ownership of this reported assay, of this reported result. So for me, it's the length of the French fry that is important, not the length of the ketchup.
Thank you, Mr. Gontard. Our second question actually is a two-part question. It asks, in your experience, which individuals in the lab and hospital does TCO most resonate strongly, most strongly meet with? And the methodology makes great sense to me, but how do I alleviate the importance to get buy-in across my organization to do such an in-depth look at our processes?
So, the first people that are interested in the TCO approach are usually the production people, whether the head of production or the head of departments, because usually they get beaten up by management and by accounting for not delivering cheap enough results. And it's always the same question. It is, how do you want us to deliver cheaper results? Because the processes and the technology are out of reach. I was in a university hospital that said that they procured a certain solution because the management imposed it on them, and they didn't have much choice. What we see after the production people is the accounting and procurement people get interested, because guess what? TCO enables efficiency, and therefore the EBITDA, earning before interest and depreciation, to improve. So if the EBITDA of the laboratory improves because the technology is better used, then procurement looks like a hero, production looks like a hero, and accounting can evidence it. So what we have seen is that all this without the internal audit is non-validated numbers. So this is why we tend to integrate internal audits together with the production people as the core team, and I spend my time educating my staff, and I must say that in the first year in every lab we do about 20 internal seminars of 3 days of how to apprehend the TCO, and after the first seminar people start running on the ground and be efficient themselves, and the low-hanging fruits start to show very, very fast. I can give you the example in France. We started deploying the TCO methodology and the seminars in May of this year, in May of 2016. Sorry, I didn't notice we changed year. And we're now end of January, and we have improved nominal EBITDA by 5%. So I don't want to disclose the EBITDA of that laboratory, but usually the EBITDA of commercial laboratories in Europe is anywhere between 12 and 20 something percent. So 5% out of 12 is enormous, and 5% out of 20 something percent is already a lot. So the people start to buy in very, very fast, and they can run themselves very fast, because most of the things that we improve or that we evidence through the TCO are things that the production people and the workers in the laboratory have been saying, but they got tired of saying it because nobody was looking at, or because it was not easy to evidence the impact of what they were saying.
Thank you for that answer. Our next question asks, how do you measure and include the impact of informatics in your methodology?
This is a tricky question, and I think it would take more than a few minutes to answer. Nevertheless, informatics, the first thing we do in all the labs we work in is to do an assessment of the ecosystems of systems that we have deployed, and how to collect data from it, and how to objectivize the data that is collected. This is the first step. Once we have reached that, we can show, and we have, I manage a group of laboratories that are $100 million and over in revenue, some of them much larger, and they have, most of them, if not all of them, multiple production sites with multiple ecosystem of informatics. And we see the impact of one informatics against the other, because it's not easy to unify. It takes a few years to unify the ecosystems through the middleware. Changing an LIS is an endeavor that takes at least 18 months if it's planned very efficiently. And most of the time, to change informatics or to improve informatics, you need to improve the philosophy of the production, the philosophy of the catalog. Do you have a unified catalog? Do you have a unified production system? Then, once you have these two elements, you can have a unified informatics. But we quantify, for example, validation versus auto-validation. We quantify sites that have middleware versus no middleware. We quantify how easy it is to do a rerun when you have a middleware versus when you're directly plugged into the LIS. So yes, it shows, and we quantify it in the model, and we see it in the model, and that also enables the people that are dedicating time to do the selection of parameters and the selection of variables to program the informatics to do their work better. And informatics is the key. A big laboratory medicine, a big laboratory is nothing else but a logistics concept. You have a logistics of biomaterial, you have a logistics of money, and you have a logistics of data. And the only thing that these three things have in common is informatics. So of course informatics should be quantified, and a wrong choice in informatics can almost kill your laboratory. So it should be very, very clearly identified, so you can do the changes and prepare the changes soon enough, because if you don't, and the environment around you changes, then you will have a very, very hard time to fix your boat and face the storm at the same time.
Thank you for that answer. It looks as though we only have time for one remaining question, and that question asks, what elements of TCO do you believe can be worked into contracts or tenders? How easy are these things to measure and track?
This is the whole purpose of TCO, is to transform the relationship between the various stakeholders, but most importantly with the technology provider. So of course TCO is designed to be integrated at least for some elements into the contracts. And I told you earlier, for example, in CityLab, we have TCO elements in the supplier's contract where we have the supplier bind itself not only to the CPRR but to the total cost per reported result. For example, for glucose, it is 31 ruble plus 4%. If the total cost is over, then the supplier has 3 months to help us and to come and intervene on our platform to help us reach back the value that is integrated into the TCO. Otherwise, there's some financial penalties or non-financial penalties that kick in, where they need to deploy additional people to help us remap the process, or they need to change some element because some element of the production platform are obsolete and generate overcosts that are not manageable. And frankly speaking, we do TCO on every single procurement decision, and when we consider a new platform from a new provider in a group of laboratories, we tell this provider that we have a certain budget for each reported assay, and that if they accept the contract, they will bind them to this budget, and if at the end of the first year the total cost of producing these assays is 25 to 35% over the cost of this budget, but it can be much lower percentage of variation. I'm talking about Russia, where things are a bit more wild, and you need to be a bit more tolerant on the variations, because sometimes the supplier is victim of systems that they don't control. Then you have the possibility to unilaterally review the contract and sometimes break it, because basically you signed the contract on a premise that is not delivered over time, and your situation is worse after the contract than before. So they have the capacity to remedy the TCO components that are not in line, but we also have the capacity to walk out should it prove to be very inefficient to produce. I hope I have answered your question.
Thank you. Mr. Gontard, I would like to thank you once again for your presentation. Do you have any final comments today?
My final comment is always the same. It is only by doing that you will learn, and it is only by educating your staff that you will progress. You cannot purchase a TCO methodology. You need to do it yourself, and you need to start with simple TCO models, and you need to educate yourself and your staff in the methodology and how to deploy it. And as I said before, in France, which is a very conservative country when it comes to changing minds and habits, in 8.5 months we have already dramatically improved things, and I can only focus and re-emphasize the necessity of educating your staff and bringing evidence-based management to laboratory medicine, which is the evidence in evidence-based medicine. Thank you.
Thank you. And I'd also like to thank our sponsor, Abbott, for making today's educational webcast possible. This webcast can be viewed on demand through August 2017. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. I'll see you next time here at labroots.com. Goodbye.